Some important disorders of adrenal system that we need to know, of the adrenal glands. So the most important disorder that we need to know here about is congenital adrenal hyperplasia. So we need to know about congenital adrenal hyperplasia. But before that, we need to have a little bit idea about the normal pathway of the adrenal hormone synthesis. So, three classes of hormones are produced: the mineralocorticoids, glucocorticoids, and the sex steroids. Okay. So, this is the mineralocorticoid pathway, this is the glucocorticoid pathway, and this is the sex steroid pathway. Okay. So, the precursor of all the adrenal hormones is cholesterol. What happens from cholesterol? The pregnenolone is formed, then progesterone, deoxycorticosterone, corticosterone, and finally aldosterone. So, what is important to note here is the sequence of enzymes in the mineralocorticoid and glucocorticoid pathways is 3, 21 and 11. Similarly, 3, 21 and 11. The mineralocorticoid pathway and the glucocorticoid pathway. The sequence of enzymes is 3, 21, 11. So, 3 beta hydroxysteroid dehydrogenase, 21 hydroxylase and 11 beta hydroxylase. Glucocorticoid pathway also it is 3 beta hydroxysteroid dehydrogenase, 21 hydroxylase and 11 beta hydroxylase. So, 3, 21, 11. Remember the sequence of enzymes. And remember that the enzyme 3 beta hydroxysteroid dehydrogenase is common to all the three pathways. That means this enzyme is common to the mineralocorticoid pathway, glucocorticoid pathway as well as the sex steroid pathway. So, this enzyme is common to all the three pathways. So, if this enzyme is affected, all the three pathways will be affected. So, with this background, let us move on to see what happens in congenital adrenal hyperplasia. Okay. So, congenital adrenal hyperplasia can practically be due to any of the enzymes which are there in this pathway that we discussed. So, the other enzymes here are the 17-alpha hydroxylase, which helps in conversion of mineralocorticoid to glucocorticoid, okay, and 17-20 lyase, so glucocorticoid to sex steroids. So, most commonly this CAH is due to deficiency of which enzyme? The answer is 21-alpha hydroxylase, very important. The next common is the 11-beta hydroxylase after that, okay. So, let us see what happens in classical 21 hydroxylase deficiency. So, remember the sequence of enzymes 3, 21, 11. So, 21 hydroxylase deficiency means this enzyme is deficient. So, what is happening is in the mineralocorticoid and in the glucocorticoid pathway, the pathway is not going below this, okay. So, below this the pathway is not going. But in the sex steroid pathway there is no problem, right. So, no mineralocorticoid is getting formed, okay, no mineralocorticoid is getting produced. So, what will happen? No aldosterone. What is the function of aldosterone? Absorb sodium and water, excrete potassium. No mineralocorticoid, then what will happen? Sodium and water cannot get absorbed. So, the child will have salt wasting, dehydration, and potassium cannot get excreted. So, hyperkalemia. Again, what will happen due to glucocorticoid deficiency? The child can have shock, hypoglycemia, okay, right? So, what will happen? Because the mineralocorticoid and glucocorticoid pathway cannot get completed, all the precursors will get shunted in excess to the sex steroid pathway. So, excess of sex steroids will be formed. So, this excess of testosterone will give rise to ambiguous genitalia in a female. So, a female baby will have genitalia like that of male because of the testosterone, excess testosterone. But male babies, the genitalia will remain normal, will appear almost normal because excess testosterone already male genitalia. So, it cannot cause much changes in that. But when these children grow up, they can have precocious puberty, these males, because of the excess testosterone. Okay. So these are the features of classical 21-hydroxylase deficiency. Another thing to appreciate is because the mineralocorticoid and glucocorticoid are not there, so they are not able to exert a negative feedback on the ACTH. So what will happen? The brain will give a signal that no glucocorticoid, no mineralocorticoid is there. So produce more and more of these hormones. So more and more of these precursors will be formed. So more and more of sex steroids, more and more of pregnenolone, 17-hydroxypregnenolone, progesterone, excess of these will be produced. And there will be hyperplasia of the adrenal glands. So congenital adrenal hyperplasia. Okay. So clinical features, we already mentioned what will happen. So there will be salt wasting, dehydration. Okay. So clinical features would include salt wasting, dehydration in both male as well as female babies. But there will be ambiguous genitalia in females because of excess testosterone. So ambiguous genitalia in females. Okay. So you can see that the genitalia of this female baby appears like that of a male, ambiguous genitalia. What are the electrolyte abnormalities that we will get? So mainly we will get elevated potassium levels, hyperkalemia. Because aldosterone is not there, so potassium cannot get excreted. So the most important finding will be hyperkalemia. We may get some hyponatremia. Now, a very important screening test for 21-hydroxylase deficiency is doing 17-hydroxyprogesterone levels. So, because this pathway cannot progress, excess of this will accumulate, okay? Excess of 17-hydroxyprogesterone will accumulate, excess of progesterone will accumulate. So, you can do this 17-hydroxyprogesterone levels for screening for 21-hydroxylase deficiency. So, this 17-hydroxyprogesterone levels are elevated and it can be used as a screening test for 21-hydroxylase deficiency. Genetic tests, you can do the mutation analysis. So these are autosomal recessive disorders and you can do the mutation analysis for congenital adrenal hyperplasia. The genes are present on chromosome 6. And doing these genetic tests will also help us offer prenatal diagnosis to a couple who already has a child with CAH. Okay. What is the treatment of congenital adrenal hyperplasia due to 21-hydroxylase deficiency? So what is deficient here? The mineralocorticoids are deficient and the glucocorticoids are deficient. Okay. So the treatment here is we use basically, so the treatment includes the use of hydrocortisone. So tablets of hydrocortisone are actually available which can be used. So use of hydrocortisone and fludrocortisone, which is a mineralocorticoid. So hydrocortisone, which is a glucocorticoid, and fludrocortisone, which is a mineralocorticoid. They are used in the treatment of congenital adrenal hyperplasia due to 21-hydroxylase deficiency. Now let us see what happens in 11-beta-hydroxylase deficiency. So remember the sequence of enzymes again, 3, 21, 11. Okay, so here the problem is in 11 enzyme, 11-beta-hydroxylase. Okay, so this enzyme is deficient. So what is happening in the mineralocorticoid pathway? Let us see. So aldosterone is not getting formed. Okay, but the deoxycorticosterone that is formed in excess and this has got mineralocorticoid activity. So because of the mineralocorticoid activity which is in excess, there is increased sodium and water absorption. So hypertension is a very important feature of congenital adrenal hyperplasia due to 11-beta-hydroxylase deficiency. Why? Because this deoxycorticosterone is produced in excess and this has got mineralocorticoid activity like aldosterone. So excess sodium water will be absorbed, so hypertension. And excess sodium potassium can get excreted, so hypokalemia can be there. Now this 11-deoxycortisol is also produced in excess, and this has got glucocorticoid effect. So what will happen? So because of excess glucocorticoid, no symptoms of glucocorticoid deficiency. So no shock, no hypoglycemia. But because these two pathways are not getting completed, so these two pathways are not getting completed fully, excess metabolites are still getting shunted to the sex steroid pathway, right? So excess of androgens are also getting formed. So this excess of androgens lead to virilization of the female. So the female still will have ambiguous genitalia in 11-beta hydroxylase deficiency, but instead of salt wasting, there will be hypertension. Instead of hyperkalemia, there will be hypokalemia in 11-beta hydroxylase deficiency, and we know why. Because this deoxycorticosterone has got mineralocorticoid effect. Okay. So let us see what happens in 3-beta hydroxysteroid dehydrogenase deficiency. So remember, this 3-beta hydroxysteroid dehydrogenase enzyme is common to all the three pathways. So let us see, the defect is here. So what will happen? No mineralocorticoids getting produced. So there will be salt wasting, dehydration, hyperkalemia. No glucocorticoids getting produced. So what will happen? So there will be features of cardiovascular collapse, hypotension, shock, hypoglycemia. Now excess of this DHEA is formed. So all these metabolites are shunted to the sex steroid pathway. But that pathway is also not getting completed. Okay, but excess of this DHEA is formed. So excess of this dehydroepiandrosterone is formed. Okay, excess of these are formed, but this is a weak androgen. DHEA is a weak androgen. So even though excess of this androgen is there, but females will not have ambiguous genitalia, because you know DHEA is a very weak androgen. So females can just have some subtle features of androgen excess like hirsutism, acne, okay, while males can have underdeveloped genitalia because DHEA is a weak androgen. It is not as strong as testosterone. So in 3-beta hydroxysteroid dehydrogenase deficiency, because of decreased aldosterone, decreased mineralocorticoid activity, there will be salt wasting, and hyperkalemia or increased potassium levels. Because of decreased cortisol, there will be shock. Okay, cardiovascular collapse or shock will be there. Hypoglycemia can be there. Okay. Now, increased androgens is there, but which androgen is increased? It is mainly DHEA, dehydroxyepiandrosterone. Okay. So, DHEA is a weak androgen. So, what will happen? So, because DHEA is a weak androgen, in males, you can get bifid scrotum, hypospadias, undescended testes or incomplete virilization. So males can have ambiguous genitalia or under virilization because of the weak androgenic nature of DHEA. While females can get subtle features of androgen excess like irregular menses, hirsutism, acne. So that is what happens in 3-beta hydroxysteroid dehydrogenase deficiency. Now let us see what happens in 17-alpha hydroxylase deficiency. So where is the 17-alpha hydroxylase enzyme? Here. So the deficiency, the defect is here. So what will happen? So the glucocorticoid pathway not functional. Sex steroid pathway not functional. So what is happening? Excess of these mineralocorticoids is getting formed. So excess of aldosterone is there, right? So excess of aldosterone means what? Excess mineralocorticoid, so excess sodium and water getting absorbed. So hypertension, hypokalemia. And excess of this corticosterone is also there. So this has got glucocorticoid effect. So no features of glucocorticoid deficiency. But there is absence of sex steroids. In the absence of any sex steroid, the default genitalia is female. So here the males will have ambiguous genitalia, looking like that of a female. But females, even though their genitalia will look normal at birth, they will have failure of sexual development at puberty because no sex hormones are there. So at puberty, sexual development is not going to happen, neither in females nor in males. Okay. So 17-alpha hydroxylase deficiency, because corticosterone is present. So there are no features of, so 17-alpha hydroxylase deficiency, because corticosterone is present, there are no features of glucocorticoid deficiency. Increased aldosterone is there. So excess mineralocorticoids are there. So what will happen? There will be hypertension. Excess sodium and water will get absorbed. Okay. And absent sex steroid. So sex steroids are absent. So what will happen? In males, we can get male pseudohermaphroditism. That means male genitalia will appear like that of a female. While females, there will be normal genitalia at birth but failure of sexual development at puberty. So that is what happens in 17-alpha hydroxylase deficiency. So now in a nutshell, to summarize about congenital adrenal hyperplasia, how do you diagnose from a given scenario which enzyme defect? Very, very important, has been asked in MCQs multiple times. So now that we have understood that in which enzyme deficiency, which feature is there, let us summarize it. So if we are getting female virilization, that means ambiguous genitalia in a female along with hypertension. So we think of 11-beta hydroxylase deficiency. Ambiguous genitalia in a female with salt wasting, 21-hydroxylase deficiency. Ambiguous genitalia in males with hypertension, that means what? Excess of mineralocorticoid getting formed. So 17-alpha hydroxylase deficiency. Ambiguous genitalia in males with salt wasting, that means mineralocorticoid also not getting formed, sex steroid also not getting formed properly. So all the three pathways are affected. So 3-beta hydroxysteroid dehydrogenase deficiency. So that is how from a given scenario we can make out which enzyme is deficient in that type of congenital adrenal hyperplasia.